All right, so I am going to talk now about the secondary survey and history taking in a trauma patient. So here's the thing. You will get here with most of your trauma patients. Most of them are going to be conscious. It's very rare that you really have a critical trauma patient. It doesn't happen often. So you're going to get here with most of your trauma patients, but you still want to wait until after your primary survey is completed and you've corrected any life threats. Do not hold critical patients in the field for secondary survey. Your secondary survey is going to be stepwise and organized. It's going to be the same for every patient, the same way every time. Superior to inferior, so head to toe. And proximal to distal, so relative to your extremities. Start closest to the bodies. Closest to the body and then move outward. You're going to look, listen, and feel as you do this survey. So again, this is the secondary survey, I guess, can either be a head to toe, which we call a detailed, or it can be a focused exam. And we've talked a little bit about when to do the detailed versus when to do the focused. The detailed is everything. I'm looking at every single detail of this patient. And the focused exam is a single area or a single system type complaint. So the detailed, this is actually going to be most of your trauma patients. The focused is going to be more rare in trauma. And the reason for that is trauma has a tendency to cause multiple systems to be affected. Even something as simple as a fall can lead to all sorts of different injuries. For example, somebody falls forward, they land on their wrist. Their chief complaint is a broken wrist. But my next question is going to be, okay, well, I know you braced yourself with your wrist, but then what happened? Did the rest of your body fall and hit the floor? Did you have any trauma to your face or to your head? What caused it to happen in the first place? Did you trip over something? Did you roll your ankle? So even in something as simple as a conscious patient who had a fall, I'm going to do a head-to-toe exam. Focused exam may be isolated to something like, I hit my finger with a hammer. And you can still ask, okay, did you hit anything else? Did you come back and hit your head with the hammer? Anything else hurt? No? Okay, that's when I can really focus in and just look at the injured finger. But even a sprained ankle, somebody rolls their ankle and they usually fall to the ground. That means they've had additional trauma. So you need to assess everything for every possible injury. Taking a history is going to be the same as with a medical patient, but you're going to ask really fewer questions about what happened because we kind of know. They can tell us kind of the story of the trauma, and that's it. That generally tells us what we need to know about injuries. So we're going to get the patient's chief complaint, and that is what the patient says the problem is, but it's not necessarily what you see. Then you're going to go and get a sample history like we've talked about, and do your OPQRST for your pain and any other symptoms. I'm going to talk a little bit now about definitive field care. Definitive field care basically means that we have a patient who is minor injuries. This is going to be your stable patients, right? So nobody who's got low blood pressure, who needs help breathing, or anything like that. So this is going to be something like bandaging, splinting, and doing things that may take a little bit of time, but it's on patients who are stable. It's going to make them more comfortable and less likely to have problems in the future with the injury that they've sustained today. So stable patients can receive attention for individual injuries before transport. Again, bandaging, splinting, so this could be maybe some abrasions. Splinting, broken or sprained or possibly broken bones. At this point, you do want to reassess carefully for hidden problems. It may be that the patient's in so much pain from the broken wrist that they have that they forgot that they hit their head and they have a big old goose egg on the side of their head. If the patient becomes unstable at any time, you want to be sure to transport. So reassessment. Once we've done our secondary survey, we've gotten our history, we are going to reassess our patient. So we're going to reassess our ABCs. And I know I never told you to get initial vital signs, but you're going to kind of get those at the beginning of your secondary assessment. When you reassess, you want to get a full set of vital signs. So blood pressure, heart rate, respiratory rate, and then ask about pain. Always good to ask about pain when you get vitals. Continue any stabilization of identified problems. This could be more splinting or bandaging. And then reassess anything you've already done. So if you've already bandaged or splinted, be sure to check pulses, make sure they still have pulses in their extremities, and check any bandages, make sure they haven't bled through them. You're going to do a continued reassessment again for any unidentified problems. And that's really it for your assessment. The next thing really do is, call your radio report, make sure you've communicated with your patient about what's going on, and get them to wherever it is that they need to be. So if you have any questions, be sure to bring them into class. Thanks.